Good morning and welcome to the July XLPAD webcast session. I'm delighted that you all have taken the time to join us and most appreciative of Dr. Mary McDermott, who is the professor of the Feinberg School of Medicine at Northwestern Chicago. It's a delight to have you, Dr. McDermott, today. And before I hand it over to Dr. McDermott, I just want to say a few words about her. I've followed her publications and scientific work for the last many years, and I can tell you that there's no one better to address the issues of comprehensive adult care, peripheral vascular disease, and preventative medicine. It's cutting. I can't go over all the accomplishments of Dr. McDermott. That will be a full 20-minute session, but briefly that she's, at this point, the chair of the Peripheral Vascular Disease Council of the American Heart Association, and also the senior editor at the Journal of American Medical Association. She has published so much that it is hard to encompass all of that in this brief introduction. However, what I'm looking forward very much to is her RESTORE study. I'm not sure when the results will be out. But with that brief introduction and lead, I'll hand it over to Dr. McDermott to take us through home-based exercise therapies for peripheral artery disease. Two more brief announcements. I would urge all of you to mute your lines. However, this is an interactive session, and after Dr. McDermott has completed her presentation, the session will be open for Q&A, including a Q&A posted online along with a reference article and the recording of the presentation within a day or two after this session. Thank you very much, Dr. McDermott, for joining us this morning, and please take it away.
Thank you. Thank you very much for that kind introduction, Dr. Bandry. Good morning to everybody. I'm going to be speaking to you this morning about home-based exercise for peripheral artery disease. I'm having trouble advancing my slides, actually. Okay, great. So what I'll be first talking about is our GOALS trial, which was a randomized trial of an exercise behavioral therapy for lower extremity peripheral arterial disease patients. And then toward the end of the presentation, I'm going to review in general behavioral exercise therapies for people with PAD. And I'll say that in the last 3 or 4 years, there have been several important studies published demonstrating that home-based exercise can benefit people with PAD. So I'm going to focus on a paper that we recently published in the Journal of the American Heart Association entitled Unsupervised Exercise and Mobility Loss in Peripheral Artery Disease, a randomized controlled trial. In way of background, people with peripheral artery disease or PAD have greater mobility loss and faster rates of functional decline than people without PAD. And current clinical practice guidelines recommend supervised treadmill exercise for people with PAD. But most people with PAD don't participate in supervised exercise programs, and there are several reasons for that. One is that medical insurance, including Medicare, doesn't pay. And also supervised exercise requires traveling to the exercise center typically 3 times a week, and this can be burdensome for people with PAD. As of today, clinical practice guidelines for PAD patients say that there's not sufficient evidence to recommend that people with PAD go home and walk. Now, as I mentioned at the start, the good news is that in the last several years there have been several new trials suggesting that home exercise can be effective, and that's what we'll be talking about today. So one of the 3 trials published in the last several years is our GOALS trial, and this is a randomized controlled trial in which we studied whether a behavioral intervention, a group-mediated cognitive behavioral intervention, can improve multiple outcomes in patients with peripheral artery disease. We studied the association of this intervention with improvement in walking endurance, measured by the 6-minute walk and treadmill. We studied physical activity as an outcome, mobility loss, and quality of life. So the design of the trial is this. It was a randomized controlled trial. We had two parallel arms, the intervention arm, which was the behavioral intervention, and a control group. And I'll be talking more about the intervention, but in both of the groups, the participants came weekly, once a week, to the medical center for the intervention for a 6-month period. And then we repeated our baseline measures at the 6-month follow-up time point. And then people were transitioned to telephone contact only. And the purpose of that, for another 6 months, and the purpose of that was to see whether changes observed at 6 months could be sustained with continued telephone contact only. And our primary outcome was change in the 6-minute walk at 6-month follow-up, but we repeated many of our outcomes at 12-month follow-up to see if the benefits were sustained over time. So more about the intervention and control groups. The intervention group was, as I mentioned, weekly on site for 6 months, and then transitioned to telephone contact only for months 7 through 12. And in the telephone contact, we reinforced the concepts that were taught in the first 6 months. And then the control group, phase 1, it was an intention control group. So phase 1, the first 6 months, we also had weekly on-site sessions, but these were health education lectures. And the point here was to give the people in the control group similar attention, but not give them any tools that would help them adhere to home-based exercise. So we would give them lectures, but we did not discuss exercise in those lectures. And then after the first 6 months, they were also transitioned to telephone contact only, we would call them, and just give information but nothing about exercise. Now, the behavioral intervention, this is how it worked. It was a group-mediated intervention, and by that I mean people came and met with other PAD patients. So we would assemble a group of PAD patients who would meet together once a week for the first 6 months with a facilitator. And they'd get to know, the PAD patients would get to know each other. There'd be a discussion, a group discussion that lasted maybe 25 minutes. And in those sessions, the facilitator would have a topic to review that was related to their exercise. So it might be dealing with ischemic pain during exercise, or setting goals, or dealing with setbacks. So there'd be some discussion about that, and the group would share their own experiences. There'd be a little bit of walking because they met at a center where they could walk around a track. And the sessions focused on behavioral change principles that we know work, because behavior change is difficult. So the social cognitive theory focuses on meeting patients where they are in terms of behavior change, having them set goals, having them self-regulate, meaning having them keep track of what they're doing, are they meeting their goals, and then giving them group support. And then in phase 2, months 7 through 12, the group was no longer in existence. We disassembled the group after the 6 months, but they would continue to receive a telephone call from the facilitator. And those initially in phase 2 would be every other week, and then they decreased in frequency to once a month for the last 3 months. So for the last 3 months of the trial, it was just once a month telephone calls, which would last maybe 10 minutes with the facilitator. So that's the intervention. And then the attention control in phase 1, where the patients were coming to the medical center, we would get experts from the medical center, professors, pharmacists, nurses, to give them lectures on topics of interest ranging from nutrition to screening for cancer to vaccines to management of high blood pressure. And then during phase 2, when they were just getting the telephone calls, we would have a coordinator call them and just review some of the information from the first 6 months. And again, it would be about a 10-minute call at the same frequency that the intervention group was getting. So our outcomes are shown here. Our primary outcome was walking endurance, and we measured that objectively with the 6-minute walk test. Our secondary outcomes included treadmill walking time. We used patient-reported walking ability with the Walking Impairment Questionnaire. This is a PAD-specific questionnaire where participants indicate the ease with which they can walk increasing distances, walk at certain speeds, or climb stairs. We measured physical activity objectively with an accelerometer. And then we had some exploratory outcomes, which included mobility loss. Now, mobility loss is becoming unable to walk up and down a flight of stairs or walk a quarter mile without assistance. So if patients became unable to do one or the other of those, they were considered to experience mobility loss. We did these measures at 6-month follow-up, and then most of the measures were repeated at 12-month follow-up, again, to see whether the benefits from 6 months were sustained after an additional 6 months with the telephone calls. So results, we randomized 194 eligible participants with peripheral artery disease into the trial. You can see the flow of the study, which I've reviewed. So in phase 1, months 1 through 6, both of the groups, the intervention and the control, came to the medical center once a week to get their assigned group. We lost a small number of people to follow up during that first 6 months, but we had about 92% completing the 6-month follow-up testing. And then after that, we transitioned them to phase 2, telephone contact only. I had a small amount of loss to follow-up before the final 12-month follow-up testing. And characteristics of the participants are shown here. It was a fairly typical PAD population. The average age was about 70 in both groups, 50% male. You can see one of the unique things about the trial was that we had a high proportion of African American participants, 40 to 50%. Average ABI values are shown here, about 0.67 to 0.68, and then although 90 to 95% of the participants had ever smoked, only about 20 to 25% were currently smoking while they were in the study. So our primary outcome, which we actually first published, we published a primary outcome 2 years ago in JAMA, and we found that at 6-month follow-up, patients randomized to the behavioral intervention shown in the yellow bar here had a significant gain in the 6-minute walk of 42 meters, which represents a clinically meaningful change. And then in comparison, the control group declined in their 6-minute walk at 6-month follow-up. And then this is the secondary outcome of treadmill walking performance. This slide shows you both the total time walked on the left side of the graph, and then time at the onset of leg symptoms on the right side. And you can see in the yellow bars, the home-based group had significant gains, significantly greater gains compared to the control group shown in red. Physical activity also improved in the intervention group. This was measured, as I mentioned, with the vertical accelerometer. These are simply activity units on the y-axis. Really meaningful to just compare within the study, but there was significantly greater gain in the intervention compared to the control group. Now I'm going to show you some of the 6 and 12-month data, and this first slide is showing change in the 6-minute walk. We've seen the 6-month data. Now you can also see that at 12-month follow-up, so after the main most potent aspect of the intervention was taken away, we still continue to see greater 6-minute walk performance at 12-month follow-up in the intervention group shown in red. However, there was a bit of a loss. So you can see if you look at these lines that the difference between the intervention and control was not as great at 12 months, but it was still statistically significant at 12-month follow-up. And this slide shows results on the upper left-hand graph. You can see the Walking Impairment Questionnaire Speed Score. So this is the degree to which the participants felt that their walking speed in daily life had improved. And the intervention group had significant gains both at 6 and at 12-month follow-up. So the gains persisted throughout the 12 months. Going to the physical activity, right upper slide, we had seen already the improvement at 6-month follow-up, but at 12 months, there was no longer a significant difference between the control group and the intervention. Going to the bottom of the slide, the Walking Impairment Questionnaire Distance Score, we saw gains at 6 months. Those were gone at 12 months. And this is a measure of the participants' perception of their walking endurance. And then finally, we did not see changes in the participant perception of stair climbing. And this is perhaps because our intervention really did focus on walking exercise and didn't focus on improving stair climbing ability. Now the results for the mobility. And here, this slide is focusing on the people that, when they came into the study, could walk up and down one flight of stairs and walk a quarter mile without assistance. Focusing now on the top figure on this slide, you can see that the red is showing the control group, the blue, the exercise. And at 6-month follow-up, patients in the control group had a mobility loss rate of around 25% compared to only about 6% in the intervention group. At 12-month follow-up, there was still quite a difference in mobility loss between the two groups. Now, when we drilled down and we looked separately at the walking a quarter mile component of mobility loss versus the component of stair climbing component, the gain was all coming from the ability to walk a quarter mile. So again, the intervention was successful at improving walking endurance, but didn't really improve stair climbing ability. On this next slide, this is the inverse of what I just showed you. So here we're looking at people who came into the trial telling us that they had trouble walking a quarter mile without assistance or walking up and down stairs without assistance. And we looked at the rate at which they regained mobility. And still the exercise group is shown in blue. Looking at the top figure on this slide, you see there's a significant gain of about 70% in the exercise group in the becoming able to walk a quarter mile or climb stairs. That's not being observed so much in the control group. And this persisted at 12-month follow-up. Looking at the bottom of the slide, again, we see that most of this gain is coming from the ability to walk a quarter mile without assistance, and not so much difference in the groups for the stair climbing outcome. So to conclude for the goal study, at 6-month follow-up, our group-mediated cognitive behavioral intervention improved the 6-minute walk, improved physical activity, and improved patient walking ability, prevented mobility loss, and functional benefits persisted for some, but not all of these outcomes at 12-month follow-up. For the mobility outcome, however, the benefit was observed strongly at both the 6 and the 12-month follow-up time points, and most of the benefit was coming from the participants being able to walk the quarter mile without assistance. So the bottom line for the GOALS trial is that our intervention, in which the PAD participants were doing most of their walking at home, we were asking them actually to walk for exercise 5 days a week at home, and this improved their walking endurance and it prevented mobility loss. And even when we took away those on-site visits where they were coming once a week and meeting in a group, we continued to see benefits for many, not all, but many of the outcomes at 12-month follow-up, and we certainly saw it for the mobility outcome. Study limitations include that the group approach takes some effort because one has to assemble a group of PAD patients. Our groups were we try to get at least 4 people. Typically there were 5 or 6 people in each group, but we'd have to wait for a group to accrue and then we could start a group. Now, in the remaining minutes, I want to tell you about two other trials on home-based exercise for PAD patients that have been published since 2011 and have demonstrated benefit. And then I'm going to sum up by telling you what are some of the consistent themes across these three studies that perhaps we can take away to clinical practice. So the other two studies were both conducted by Andy Gardner, and one of them was, the first one was a study of 119 participants with claudication. This was a 12-week intervention, so it was shorter than the GOLDS trial. He had three groups. He had a supervised treadmill exercise group where participants exercised 3 days a week for 40 minutes, a home-based exercise group where participants were asked to exercise at home for 3 days a week for 45 minutes each session. They were given walking monitors to wear, and they would come in every other week to the study center, and their monitor would be reviewed with an investigator who would give them feedback, set goals for the next 2 weeks, and then they'd go out again, come back every 2 weeks. And then he also had a usual care group that really didn't get anything. So here are the primary results for this trial. His primary outcome was change in peak walking time. The blue bar shows that the usual care group had a bit of decline. The red bar shows the supervised exercise group. They had a significant gain in treadmill peak walking time, and the home-based exercise group also had a significant gain, as both of these better than the change in the control group. No difference here between the supervised and the home-based exercise groups. They both improved. One was not significantly better than the other. The other trial was also by Andy Gardner, published just a few months ago, actually I guess now about 9 months ago. 180 participants, again 12-week trial, randomized to three groups again, supervised exercise, home-based exercise, or control. Here, the difference in this study was that the home-based group came to the medical center only once a month. And the home-based group was also advised to walk 3 days a week. They were again given a step counter. I realize there's a typo on the slide because they only came to the medical center once a month. So it was pretty hands-off. And here are the primary results for that trial. The supervised group shown in the middle there had significant gains, and so did the home-based group shown on the rightmost bar on the slide, and these gains were significantly greater than the control group. Again, for this, there was no difference between the home and the supervised groups in terms of their degree of benefit. And then here for the 6-minute walk outcome, which he measured in this trial, both the supervised and the home-based group had improvement compared to control. Here the home-based group actually did better than the supervised group in the corridor 6-minute walk. So again, these two trials also show benefit, and I think remarkably this last trial participants came to the medical center only once a month and still achieved significant benefit. So in the last remaining minutes, I want to mention a few items that I think are important when we recommend home-based exercise to PAD patients. Because I still think that if we just say go exercise without giving them any guidance, that may not be successful. I think it's important to tell the PAD patients that they should monitor what they're doing. They should write down goals each week about when they're going to exercise and for how long. And usually I'll tell the patients, you may only be able to walk for 10 minutes the first week each time. That's okay. We're going to start at where you are and then gradually build up over time. So they write down their goals. They write down what they actually did. And then I do think it's important to have a coach. It does not have to be a physician. We had sometimes an exercise physiologist be the coach, and sometimes we had a bachelor's degree coordinator who was trained, and I think both can work. So giving them feedback, having them monitor what they're doing is really important. In PAD patients, the ischemic leg pain that occurs with walking is a real barrier for them. They have to stop and rest. And some of them will say it's embarrassing or they're not sure if it's safe to exercise with leg pain, and I think we need to give them the message that it is safe and that it's all right if they need to stop and rest, and then as soon as they're able, they just begin walking again. And when we give them walking exercise goals, we need to tell them that we're giving them a goal for the time walked. So if they're doing 20 minutes but they're spending 10 minutes resting, then it's really a 10-minute exercise for that session. We've found that they're often uncertain about what they should do, what's the right program for them, so giving them that information. Walking is good. Try to make it a regular habit. We tell them 5 days a week, starting low, gradually building up by perhaps increasing by 5 minutes a week till they get to 40 or 50 minutes of exercise per day. And then also PAD patients have a lot of comorbidities and they get hospitalized, and it's important the coach can really help them get back on track. They might need to take a break if they have a significant comorbid event, but then encouraging them to start again, starting slower perhaps, and then building up to where they were. These are all some of the challenges and some of the techniques that one should be thinking about when advising home-based exercise. So even though we've got several promising trials on home-based exercise, there's more work to do. I think the more hands-off a successful home-based exercise program can be, the better. So, and with the rapid emergence of technology that patients can use to track their walking and use of the internet, there's real new opportunity to be more efficient in communicating the intervention by way of the internet. I think group support might be carried forward perhaps on the internet with chat rooms or message boards that people can share experiences. And also of interest, in non-PAD patients, there's a real interest in whether just standing up and walking around in the house can provide benefits. So perhaps even less intensive exercise could be beneficial for these patients, but that needs to be studied. So in conclusion, this is my final slide. There's increasing evidence. I think we should feel encouraged that home-based exercise programs can be successful. I think that the monitoring, having the patient monitor what they're doing and giving them regular feedback are important components to successful adherence to home-based exercise in PAD. So thank you very much for your attention, and I'm happy to take questions.
Thank you, Dr. McDermott. That was a fantastic review of the data, and I think this is something we all have been waiting, especially in the revascularization community. I'm going to open the session to questions, and please feel free to ask any questions directly to Dr. Mary McDermott. And again, I repeat that there will be an opportunity to view her recording and, of course, review her articles posted on xlpad.org. So go ahead, please. While people are considering, hopefully, the questions, I have two questions. Dr. McDermott, number one, do you believe that home exercise regimen that you and Dr. Gardner and others have prescribed could become a regular accompaniment of actual revascularization clinical trials? As you can see, as you know very well, that most of the revascularization clinical trials don't come with a prescribed exercise regimen, or very much similar along the lines of the CLEVER trial from the NHLBI. And the second part of the question is, do you think that these clinical studies would ultimately pave the way for a reimbursement for home exercise monitoring that is objectively for the first time shown that it is clinically meaningful and the effects are sustainable?
Yes, thank you. With regard to the first question, could home-based exercise complement, add to revascularization? I think there's great potential there. I would point out that when trials, in addition to CLEVER, there have been a number of revascularization exercise trials, some of which have studied whether the combination of supervised exercise plus revascularization is better than either individual intervention, and those studies consistently show that if one can give a patient a combination of revascularization with supervised exercise, that combination is better than either individual intervention. So I would say yes, there's opportunity. To my knowledge, there haven't been any randomized trials to specifically look at whether combining a home-based exercise with revascularization improves outcomes to a greater degree than revascularization alone or home-based exercise alone. But based on what we know already about the fact that the combination of supervised exercise with revascularization is better than any single intervention, the single interventions alone, I would expect that the home-based combined with revascularization could be better than either individual intervention. To my knowledge, that study has not been done. And then your second question about reimbursement, I'll let you know, it's amazing to many of us in the work in this world, I'm sure people on this call as well, that even though supervised exercise has benefit, it doesn't get reimbursed. So I believe that that I know there was actually a meeting hosted by our government in this month in July to reevaluate what should be reimbursed for PAD patients. And I don't know whether out of that meeting will come reimbursement for exercise. I kind of doubt that it'll be that simple. But I think we all need to keep revisiting this and encouraging it in any way that we can. I'm cautiously optimistic that eventually exercise will be reimbursable. But clearly so far it's been quite a challenge to achieve that.
Thank you very much. Any questions from the group joining in?
I have a question. Nick Shamas here, Davenport, Iowa. The question is how much, the overall improvement in the walking capacity or distance really impact the overall quality of life of those patients. If we can improve only one aspect, of their ability to do things, but for instance, we don't impact much their ability to walk upstairs, for instance, how much the overall quality of life has been impacted by this particular program?
Well, I think the mobility loss improvement, and you're right, most of that improvement in mobility, most of the prevention of mobility loss and most of the regain in mobility came from the ability to walk greater distances. But I don't think that should be discounted because mobility loss has been linked to decline in quality of life. Mobility loss has also been linked to increased rates of hospitalization and increased rates of even mortality. So this is a very well-validated outcome. Also, with the 6-minute walk, improvements in 30 meters or greater have been linked to improvements in quality of life. In the GOALS trial, we saw a 42-meter gain, and actually slightly greater when you consider that the control group declined. So these outcomes definitely have been linked to improve meaningful outcomes, quality of life, preventing hospitalizations. Should we try to develop an intervention that can both improve walking endurance and stair climbing? Absolutely. But I don't think we should discount, this is a starting point. We can add to it and achieve even greater gains in the future.
Okay, thank you very much.
Thank you, Dr. McDermott. Any questions from the audience, either to the chat room or directly to Dr. McDermott? Please go ahead.
Dr. McDermott, I have just one question. Basically, let us say that, as we know, a lot of these PAD intervention patients, sometimes we have patients that are more in rural areas. How can we improve the supervised exercise therapies in such communities, not like in big cities, but where it's kind of hard for the patients to be compliant with exercise?
Yeah, that's a great question. This is where the home-based exercise, I think, is particularly important. And because you're right, it's a big challenge. If they don't live anywhere near an exercise center where they can go 3 times a week for supervised exercise, they're probably just not going to do it. It's not realistic.
Yeah.
But I think this is where the home exercise has particular potential for benefit. I think it's still important for them, when they come in for, say, a regular PAD visit, or perhaps after revascularization in the hospital before they go home, there needs to be an initial face-to-face contact where, giving them an activity monitor or just telling them what the program is going to be and how they should keep track. And then, again, this is also where technology can be helpful to us. They can communicate how they're doing by way of the internet, or even if they don't feel comfortable with that, even by telephone. So I think your question is exactly why we really need, one of the reasons why we need more home-based programs, because we've had patients in our GOALS trial who literally walked in their basement, but they would walk around the circumference of their basement. And when I would hear about this during the trial, I was so discouraged because I couldn't imagine how walking in one's house could improve outcomes. But at the end of the day, we did see across the board gains. So even walking around the block or walking up and down the driveway, or in some cases walking, developing a circle around the house or in the basement, seems to be effective for these patients. They're so debilitated that even a small amount of walking really seems to help them.
I see. Yeah. Thank you for your answer, Dr. McDermott.
Thank you. If there are no further questions, we are right on time, as always. And before we close today's program, just want to thank Dr. Mary McDermott one more time for taking the time from her busy schedule to participate on the XLPAD call this morning and telling us about home-based exercise program. It couldn't have come from a better expert nationally and internationally. Just want to remind that the recording of the program will be posted again on www.xlpad.org, and hopefully in the next few days we'll be able to post 2 multiple-choice questions along with a reference from Dr. Mary McDermott. Once again, Dr. McDermott, thank you for joining in, and thank you all for taking your time this morning. I hope you all found this session highly productive, and please stay tuned again to next month's webcast on another interesting topic in the management of patients with peripheral artery disease. Thank you very much, and have a great day.
Thank you.